This is part 3 of bowel elimination and GI disorders, and we're on Meckel Diverticulum. This is something left over that happened during the embryonic stage. You get a little band between the small intestines and the umbilicus, and so it pulls that small intestine, making a diverticulum. Right? A diverticulum is kind of a little sac or pouch that comes off in the intestine. And the most common symptom with this is painless rectal bleeding. Sometimes it presents with pain, though, something like an appendicitis or a bowel obstruction. They'll treat this with surgery and go in and remove that diverticulum so that we get rid of that band connecting the two. And it's usually done laparoscopically, so we've got the standard treatment that we're going to be doing, like for an appendectomy or some other GI laparoscopic surgery. Inguinal and umbilical hernias. A hernia is a loop of intestine that pops out where it shouldn't. So inguinal is down the inguinal canal, and you kind of see it up here, and into the scrotum. You get a loop of intestine here. Umbilical is the intestine pops out through the abdominal muscles into the umbilicus. You increase intra-abdominal pressure, it pushes that intestine out, right? You see a crying baby as you're changing the diaper, and you see that belly button pop up, and then it goes back down. As long as these are reducible, which means they can be pushed back where they should go, they're really not a concern. Umbilical hernias almost always resolve on their own. Actually, most by 2 years, but we'll give them up to 4 years. So you rarely need to do surgery on those. The inguinal hernia, you're likely to need to do surgery, but when it slides down there, you push it back up, and as long as it can be reduced, pushed back where it goes, we just wait until the surgery is scheduled and happens. If you try and push it back, now if the child's crying, you may not be able to, because the pressure's up and they're fighting you. But if they're quiet and you still can't get it to push back, that is an emergency and you need to notify your provider. The problem is, if it gets down there, gets swollen a little bit so it can't get back, it's now incarcerated, right? It's trapped. If it continues to swell, it can get strangulated, where you're actually pinching off the blood supply to it, and you can lose that bit of intestine. So that is a medical emergency. So as long as it's reducible, they usually schedule surgery, but it's kind of done outpatient, not as an emergency. So we're going to move on to acute disorders, and the first one is dehydration. How do kids get dehydrated? Well, most often with diarrhea or with vomiting, so that's too much loss, or not enough intake, decreased oral intake. Other things that cause dehydration are fever. A child's fluid needs go up when they run a fever, and if they're not meeting them, they get dehydrated. Our diabetics who go into diabetic ketoacidosis, they get profoundly dehydrated, and burns. There's so much fluid loss through that burnt tissue. So there's a YouTube that I think he does a good job explaining assessment of dehydration. So signs of dehydration, what I'm used to using, which our book really doesn't talk about, is weight loss to differentiate mild, moderate, and severe loss. On babies, that fontanelle we're going to use, and sunken eyes. Look at, is the mouth kind of sticky, tacky, and pale? The skin turgor, heart rate will go up. Blood pressure, I really want to point this out, is normal. Even into severe dehydration, it is normal until the child can no longer compensate, and then you will get a precipitous crash. And you are doing emergency resuscitation. So blood pressure may be something you look at early on adults. It is not something you really look at on children, and in fact, if you start to see it go down, you are in trouble. Much better is looking at their extremities, looking at the color and the warmth, right? You should be warm and pink with quick cap refill. You get a little dehydrated, that cap refill will slow down. Your skin might feel a little cool. You get severely dehydrated. Babies, children will circulate to the core, not to the periphery. So their skin, it feels cool, looks mottled. The capillary refill in their fingers and toes is very delayed. That is a huge assessment. And when you're seeing that, don't wait for vital sign changes. That requires a quick intervention. The other thing to be watching is the urine output. Babies do not concentrate their urine. They just don't pee as often. So we're looking at the quantity of urine out. 1 ml per kilo per hour, or the equivalent of that, is the lowest we want to see. You get less than that, you're probably moderately dehydrated. If you get significantly less than that, you're severely dehydrated, or a child is, not you. So our treatment is going to be with oral rehydrating solution. That is, the oral rehydration therapy is with oral rehydrating solution. That is our first and best treatment. Our book says start small with 1/2 to 2 ounces every 15 minutes. The policy at Valley Children's is even smaller. It says to start with 2 to 3 mLs every 5 minutes. And the policy at Valley Children's says vomiting is not a reason to stop. Wait till they're done vomiting and then keep trying with just a spoonful of oral rehydrating solution every 5 minutes. You can buy oral rehydrating solution, which is Pedialyte. It doesn't taste good. It tastes better if you make it really cold. You can buy popsicles of it that actually taste quite a bit better. Or you can there are recipes to make it at home, which is less expensive. Still, it doesn't taste good unless you have it cold. Water is not a good replacement because it doesn't have the electrolytes that have been lost. And high sugar drinks, including things like Gatorade that have the electrolytes, also have too much sugar, and that extra sugar can trigger more diarrhea. Babies who are on breast milk or formula can keep nursing, and breast milk, we always keep them on breast milk. Sometimes they'll might change the formula a little bit, but breast milk is not a problem. A child who's severely dehydrated, it's going to take a long time to rehydrate them. Orally, we usually want to get them up a little bit from that, empty state they're in. So we're going to give them an IV fluid bolus. At Children's, we always use normal saline. Our book says normal saline or lactated ringers, but it's 20 mLs per kilo IV, and it's usually given over 20 minutes, 20 to 30 minutes. So here's some do's and don'ts of the child with diarrhea. Give small amounts of fluid even if vomiting, and that is a do. While they're vomiting, you don't give it, but when they're done, give them a few minutes and then keep trying. Give an antidiarrheal, such as Lomatil. That is a don't. We don't want to keep the germs in there. Most of our diarrheas are viral. They will run their course and be done. The ones that are bacterial, you dump out all of the germs. So we really don't want to slow down the gastric motility. We want to let what's in there get out, and they'll get over it faster. Give an antibiotic if the diarrhea is bacterial. This is things like Shigella, Salmonella. Usually not. Again, it usually just passes through. C. difficile, Clostridium, C. diff, whatever you're used to calling it, is often an exception. But most of the time, we don't treat bacterial diarrhea with an antibiotic. Older children can drink sports drinks and clear soda as oral rehydrating solution. No, too much sugar. Okay, how about vomiting? Another way to get dehydrated. We're going to ask or observe what they did throw up. If there's bile, which is, that green or bright yellow, that's different than if they ate and what came up is just food. The force, projectile vomiting, it goes with pyloric stenosis. People use that term, but if you've never seen a baby with pyloric stenosis vomit, you don't really know what projectile vomiting is. And then timing in relation to meals. Do they eat and then throw up? What triggered it? So ask all those questions, and of course chart what it looks like, color and quantity. So we may have to give fluids. So this is how we calculate fluid maintenance. Our book gives us that first formula, and so I've got it on there. That gives you how much they need in a day. So you have to divide it by 24 in order to get how much they need in an hour to set your IV pump. Children's uses this quick estimation. It's very close, but it's not exact. We usually call it the 4-2-1 method. So anything up to 10 kilos. So say your baby weighs 8.2. You're going to multiply that by 4. If they weigh 15, the first 10 you multiply by 4. The next 5 that fell between 10 and 20 to make 15, you multiply by 2. Anything above 20 kilos. So if you have a 23 kilo kid, those last 3 kilos, you're going to multiply by 1, and you add that together. That tells you how much to give in mLs per hour. So you don't have to do any other division or math. Sometimes it may be ordered 1.5 times maintenance. So you would multiply that by 1.5, because we're not just giving maintenance, we're giving more than maintenance. So what causes diarrhea? Almost always viruses, but it can also be bacteria or parasites. So when you're assessing, you're going to count the number and frequency of stools, the stool volume, and you'll see some of the nurses at Children's, particularly in Discovery, where they do a lot of GI disorders, they measure it, they weigh it, and estimate, okay, it's 3/4 urine, 1/4 stool, and they'll actually quantify it. That is not something that I would expect you to do, or that's even done commonly. It's not done in the rest of the hospital, just in that one unit. So any associated symptoms, we want to say what that looked like. If there's blood or mucus in there, that's different. And you know, of course, is it liquid or is it semi-formed, and what color is it? Again, that helps in figuring out what the germ, what the causative agent is. This is something I put up here just because if you look worldwide, so this is not the US, but this is worldwide, preterm babies or anomalies at birth is the biggest reason that children under 5 die. And in fact, the most dangerous day of life is the first 24 hours of life. That's where most of those neonatal deaths occur. The next most common thing that children die of worldwide is pneumonia, followed by diarrhea. But in those other conditions over there, which is also a big chunk, the light blue, a number of those disorders have diarrhea as a component of them. So really pneumonia and diarrhea, if you take away those birth deaths, those are the things that kids die from globally. And oral candidiasis, which is oral thrush. This is fairly common among newborns and very common in kids who are immunosuppressed. It's thick white patches in the mouth. We treat it with an oral antifungal that works topically, so you want to make sure you get that on it. So don't give it before they eat, give it after they eat. And on an infant, you're going to put it on a little Q-tip or your spongette, toothette, and rub it on. An older kid can swish and either spit or swallow. It actually is not absorbed, so it doesn't hurt them if they swallow it, but it doesn't do anything if they swallow it. There is a once a day pill that we can give, but you've got to monitor liver if you give that, and make sure you give it with food because it causes nausea and vomiting.